And after this great presentation and introduction by Dr. O'Brien, I'll quickly go through some of the uh, clinical trial results over the last decade now, and try to make some sense of where we are. I think we've gone from having limited options to now having a wealth of different options, and it sometimes gets really challenging to decide which one to go with first and why. And, everyone has strong opinions about one way or the other. So we'll try to summarize that over the next 15, 20 minutes. So this is kind of the lay of the land right now. We started off with Ibrutinib, as we discussed before, and then in the covalent group, came up with new drugs which were more specific, less toxic, like Acalabrutinib and Zanubrutinib. And then the next big step was the non-covalent BTK inhibitors, primarily for use in patients who had failed the covalent BTK inhibitors. Both Pirtobrutinib, which is now approved and available, and Ibrutinib has been used in that setting on clinical trials, mostly for Ibrutinib. And then more recently, we've gone one step further with the BTK degraders, and there's a number of agents out there which have preliminarily shown really promising benefit. I would say that we haven't cured the disease, but we have almost made it irrelevant for a lot of patients. And there is a substantial percentage of our patients, if not most of our patients, who can expect to live to their normal lifespan now with CLL. They might need treatment on and off over their life, but hopefully they can enjoy the vast majority of their predictable lifespan. So this is, again, just to give you a historic perspective of where we started off with. The Ibrutinib was a major advance in the field, and at that point, it was compared to different agents, including chemotherapy, with or without CD20 antibody, and other available drugs that were available at that time, and it was significantly more active than all the other available drugs that we had at that point, especially in patients with del17P or TP53 mutation. So this is just one of the studies that we are showing about the RESONATE trial, which significantly improved outcomes in patients who were treated with Ibrutinib as compared to ofatumumab. We did realize very early on that Ibrutinib had a few peculiar side effects. Obviously, we were expecting to see some cytopenias in our patients, and we consistently see these with all the drugs that we have in the field. But we also saw atrial fibrillation, cardiac toxicities, and that's kind of slightly, I would encourage all of you to think of those as separate toxicities. Hypertension and atrial fibrillation, they don't go hand in hand, just like they would in an ordinary population that we might treat. Starts off with hypertension, results in atrial fibrillation decades or years later. It goes parallel in the setting of patients who are treated with Ibrutinib or BTK inhibitors in general. They tend to happen a little early in the disease course. So both hypertension and atrial fibrillation were seen in patients with Ibrutinib. There was also a signal of other cardiac toxicities like ventricular arrhythmias. And then obviously this was compounded further by the fact that Ibrutinib and BTK inhibitors in general do tend to increase the risk of bleeding, especially major and minor bleeding, which can be very problematic. So this was why it was challenging to manage those patients who had atrial fibrillation while they were on BTK inhibitors. So this was one of the earlier findings as we got more experience with the BTK inhibitors. So moving on, so can we do better? So the first step in that direction was the availability or access to Acalabrutinib, which definitely showed improvement in outcomes as compared to chemotherapy with bendamustine and rituximab, or idelalisib plus rituximab in the relapse setting. We don't use idelalisib that much anymore, but bendamustine is still used widely in a lot of the world which doesn't have access to BTK inhibitors. And even in the US, a lot of patients are still getting bendamustine, rituximab. So Acalabrutinib was compared to those chemotherapeutic and non-chemotherapeutic options and was clearly better. It did show a fairly good safety profile, and there was a nice hint that it was not causing as many issues with atrial fibrillation or hypertension, and the bleeding issues did stay with the use of Acalabrutinib, although the incidence was possibly slightly less than what we were seeing with the BTK inhibitors at that time. So it was very encouraging, a step in the right direction. We continued to see issues with cytopenias as expected, especially in our patients with CLL. Along came the more important studies. So these were the Elevate RR study and obviously we'll talk about Zanubrutinib in a little bit, but these were head-to-head comparative studies where the BTK inhibitors were compared with each other. So the first one that came out was Acalabrutinib versus Ibrutinib. There was an initial trend towards an improvement in outcomes with Acalabrutinib, but at the end of it, the efficacy was fairly similar between the two agents. There was, however, a slightly better, or I should say different toxicity profile. Headaches are unique side effects of Acalabrutinib, especially in the first few cycles, managed very effectively with caffeine. On the other hand, Ibrutinib, we saw the same issues. We saw the bleeding issues, the hypertension, the atrial fibrillation, and diarrhea and myalgias and so on. In Acalabrutinib, fortunately, the incidence of those side effects like hypertension and atrial fibrillation were less than what we were seeing with Ibrutinib. And there was possibly a trend towards a lower incidence of neutropenia with the use of Acalabrutinib, but still, we do see cytopenias with all of these BTK inhibitors. But this was one of those studies that was the first study that really compared these two agents to help us in deciding which way to go with. And subsequently, as I mentioned before, the Alpine study did the same thing in a slightly different population, so can't really make comparisons cross trials, but it was comparing Zanubrutinib to Ibrutinib, and it did show an improvement in progression-free survival. But interestingly, although the incidence of atrial fibrillation was lower in patients treated with Zanubrutinib, we do see possibly a slightly higher incidence of hypertension and neutropenia with the use of Zanubrutinib. So cytopenias are an issue with Zanubrutinib, hypertension is an issue with Zanubrutinib, and almost the same incidence of bleeding side effects and bruising and contusions and so on. So we still have to consider bleeding as a class effect rather than a drug effect when we're talking about BTK inhibitors in general. I'll come to the non-covalent in a little bit, but essentially there are minor differences here. So one may be less toxic in terms of atrial fibrillation issues, but worse for hypertension. All of them should be managed very carefully when you're talking about a bleeding risk situation. Cytopenias, again, they're all fairly similar, but one may be slightly worse than the other. But there's really no clear winner in terms of, okay, is this the best BTK inhibitors? It's all about the situation. There are some relative advantages, and those have influenced our practice over time. And as we got more comfortable and as different physicians felt that this drug was better for their patients, they started using those more. So as a result, the field kind of moved away from Ibrutinib towards Acalabrutinib and Zanubrutinib. So when we are talking about these, it is now creates another interesting dilemma, and we haven't talked about BCL2 inhibitors. We'll talk about it in a second. But essentially, now we are left with two groups of patients. One of those patients are the ones who are truly double refractory. So these are patients who have had BTK inhibitors and BCL2 inhibitors, and they've actually progressed on them or have developed resistance to them. So those are the truly double refractory patients. And then on the other hand, we have patients who are exposed to those drugs but stop for various reasons. So those are the double exposed patients. It all depends on how you start off with and how you sequence your therapies. But at the end of it, whether you start with a BCL2 inhibitor or a BTK inhibitor, you end up with a group of patients down the road. Fortunately, that can take almost a decade in some cases or more in some cases, And that's how long it took us to start seeing the emergence of more and more of these patients who were truly double exposed or double refractory. We did also see that patients who were double refractory were actually the patients which had the worst outcomes as compared to patients who were double exposed. And patients who are double exposed actually do really well, even if they have the higher risk mutations. They just tend to respond better to whatever therapy that you treat them with. And the incidence of the high risk mutations, TP53, BTK mutations, and so on, those tend to be less in patients who are double exposed as compared to double refractory. Because, if you think about it, you could have a patient who started on Ibrutinib and had hypertension or atrial fibrillation right away, and you had to stop after a few weeks. So those patients are the ones who would be expected to respond very nicely to, let's say, a non-covalent BTK inhibitor if you decided to use that in the future. So this is how we kind of think about the double exposed and double refractory when we're talking about sequencing of therapies. So let's talk about the non-covalent BTK inhibitors, which has been a phenomenal advance in the field, because after we had BTK inhibitors and BCL2 inhibitors, what do you do after that? Especially in patients who were truly refractory to those therapies, and Idelalisib and bendamustine and recycling the BTK inhibitors were not very effective, really, and the results were fairly dismal. So having the access to Pirtobrutinib as the first-in-class non-covalent BTK inhibitor that was approved, that was a huge advantage in advance in the field. One of the first studies, the Bruin CLL 321 trial, was basically done to compare Pirtobrutinib, similar to the Acalabrutinib study that I've mentioned previously. So it compared the response and outcomes of patients treated with Pirtobrutinib versus Rituximab or bendamustine rituximab, and it did show an improvement in outcomes in patients who had previously received a BTK inhibitor. So this was very encouraging. And what was more encouraging was we did not see the usual side effects of hypertension and atrial fibrillation and so on with the use of Pirtobrutinib. I do, however, would like to say that the bleeding issues tend to be less with Pirtobrutinib, but I would still be cautious whenever I have a patient on Pirtobrutinib, because I don't want to have them to deal with the bleeding issue, especially if they are planning on undergoing major procedures. Now, our experience has been phenomenal, and it seems to be well tolerated, even if you don't want to hold therapy necessarily. But I think just out of the just to be cautious, I tend to be more conservative in how I manage those patients, especially if they are planning on undergoing a major procedure, which can potentially be complicated if they had a bleeding episode with it. So that's why I tend to view it as in the same class effect of bleeding as other drugs, although the results show that it tends to be much, much better than the other drugs that we have available in the BTK class. So more recently, we got updated results at the EHA meeting and the 3-2 study. This is another important advance in the field, because prior to this, if you had a patient who had progressed from the Murano study, we had the venetoclax and rituximab combination, which was fairly well established as a very effective salvage regimen for our patients. So the addition of Pirtobrutinib to venetoclax and rituximab significantly improved outcomes, depth of response, and essentially patients were doing really well. And this was seen across all pre-specified subgroups, including patients who were exposed to covalent BTK inhibitor, including patients who were resistant or refractory to covalent BTK inhibitors, and then patients who had the high-risk del17P or TP53 mutation. So across the board, this combination was better as compared to venetoclax and rituximab. So PVR, as far as I'm concerned, if we are planning on using VR, I think it's very reasonable to consider the addition of Pirtobrutinib in that setting to salvage those patients and hopefully have a much longer progression-free survival after time-limited therapy for these patients. And more importantly, it did not necessarily result in increase in the incidence of adverse events, Even the cytopenias were slightly higher, but not that significantly. When you look at febrile neutropenia, for example, tumor lysis syndrome, actually, if anything, is better. And we've seen this when you do a run-in with BTK inhibitors, the venetoclax, the tumor lysis issues are much easier to handle and manage, and it makes it much easier to deal with those issues, and the monitoring of the patients become much easier. Atrial fibrillation is again consistently, we don't see this issue with Pirtobrutinib, and also hypertension doesn't seem to be a side effect that we see with the use of Pirtobrutinib, and that was true in the 3-2 study. So now we're thinking of two ways that we're starting to treat our patients. One is you start off with a fixed duration BCL2-based therapy, for example, venetoclax or obinutuzumab, and then you go to BTK inhibitors, covalent, and then non-covalent. So you go one by one. And then on the other hand, you started off with a continuous BTK inhibitor like Acalabrutinib, or maybe patients on Ibrutinib who are now progressing, or Zanubrutinib, and then you go from BTK to BTK. So you can go from covalent BTK to non-covalent BTK, or you can go from covalent BTK to BCL2 and then go to non-covalent BTK. So you can play it however which way you want. And I think that's really where the debate is, which is the better option, or can we move the non-covalent up the line and save BCL2 inhibitors for later, or should we use BCL2 inhibitor first and then save the non-covalent for later use? So that's the big debate in the field, and obviously everyone has their own opinions, and as we get more and more data out there, hopefully we can tease this thing out a little bit better. But as we do that, the frontline treatment keeps changing continuously, so that makes it so much harder to make up an algorithm that would fit for every patient. So very quickly, we just will talk about two drugs that are looking promising, are not available right now outside of a clinical trial, but moving forward nicely. One of them is Nemtabrutinib, that's a non-covalent BTK inhibitor, has shown some promising early results. And then the other one is Rockbrutinib, which is a bifunctional cysteine 481 BTK and a non-cysteine 481 BTK inhibitor. So dual targeting. We do see somewhat of the same side effects of bruising and bleeding issues with these drugs, maybe less so with Nemtabrutinib. But we don't see the atrial fibrillation and hypertension with these drugs. So again, promising options for our patients, and possibly they may have a role in the future as we have more and more patients progressing after either BCL2 or a BTK inhibitor. So these would be good options to have. And similarly, the biggest news in the field right nowadays has been the BTK degraders, or the Brutidegs. Now that they're called, we have Bexabrutideg, which is really looking very promising, and it has a high efficacy and also some durability. So even though the follow-up is still relatively short, but early results are very promising with both the agents that we have further along in development. The BGB 16673 drugs in the Cadence study showed really impressive early results with good responses and also durable responses. So, and again, tolerability has been pretty reasonable. We just don't know what happens to these patients long term yet, what kind of resistance mechanisms they will end up developing. So more to be known about these drugs as they get through to more patients and we get more results with these agents, but very promising options for our patients, especially if you have patients who you are considering to bridge to, let's say, CAR T cell therapy, which again is a promising option for some of our patients. So this is kind of where we are right now. How do you select patients for frontline therapy? It's about what the patient prefers. Now, there is minor nuances about whether you would go with one versus the other when you're talking about del-17P or TP53 or IGHV status. In those patients, maybe the BCL2 would not be the preferred option. And if you had an option for starting those patients on a BTK inhibitor, that would be preferred over a BCL2 inhibitor. But outside of that, you can talk about the tumor lysis issue, the back and forth monitoring. Some patients are okay with taking the pill forever. Some patients aren't. So these are all discussions that you have to talk about. But I feel that the biggest thing that we all look at is really about the cardiac issues and possibly the bleeding issues. If somebody has poorly controlled atrial fibrillation or kidney function or hypertension, those are kind of the things that are probably forefront. Obviously, if the patient has a preference, then that makes it a little bit more easy. But generally, those are some of the things that we look at in deciding which way to go in terms of BTK or BCL2. And then the next thing is continuous versus time-limited treatments. So again, these are kind of the two ways: continuous therapy versus time-limited. Obviously, cost is an issue. Time-limited would definitely be always cheaper. And then depending on how you do continuous therapy and how you do time-limited therapy, for example, if you do BTK plus BCL2, you have an oral-only option. If you want to add an IV to it in terms of triple therapy, you can also do that, but then that requires more back and forth and scheduling issues and time spent at the cancer clinic. So those are all issues that you have to think about when you're deciding about BCL2 versus BTK and continuous versus fixed duration therapy. I would say, though, generally the trend in more recently has been to go to fixed duration therapy. Now, how do you decide when to stop therapy? That's also an evolving kind of goalpost right now. Do we treat to MRD? Do we treat to a time-limited interval? And those are all discussions that are happening, and trials are being done to address these issues. So we'll quickly, in the last 5 minutes, talk about those briefly. So these are kind of the things about the continuous BTK inhibitors. Ibrutinib, we have 9+ years of results, phenomenal activity, sustained control of the disease for the vast majority of patients. So you can't go wrong with either Ibrutinib, Acalabrutinib, or Zanubrutinib in terms of long-term efficacy. So that's been well established now. But moving on to the discontinuation rate, it used to be more than 50% with Ibrutinib and lower with Acalabrutinib and Zanubrutinib. So a lot of patients do stop these drugs, and the most common reasons are infections and obviously atrial fibrillation and hypertension and so on, and cytopenia. So all of these are issues that result in discontinuation of these drugs, and so patients cannot continue this perpetually. So fixed duration has become the preferred or an attractive approach. So the CLL13 trial was one of the first ones that showed that. It answered two important questions. Obinutuzumab is better than rituximab. I think this was an important study to establish that. And then triple therapy did result in improvement in the depth of response. However, it did increase the risk of infectious complications with the use of triple therapy. Now, you can argue that if you remove Ibrutinib and combine and replace it with another BTK inhibitor, that might result in better outcomes. So that's why the AMPLIFY study was important, AV versus AVO. The triple therapy with AVO was more effective. It did result in more deeper remissions and longer duration of remission. However, if you look at the survival, it did result in increase in the risk of infectious complications, especially COVID-related mortality. And now, does that impact us nowadays? And that's some question for us to figure out. And if you can manage those patients now, it is attractive to have a time-limited triple therapy option for some patients who you feel would be lower risk for getting infectious complications and maybe get a deeper remission, which will last longer. Or you can do double therapy, which is fairly well tolerated too, without the need for an IV infusion, which requires multiple visits to the clinic. So similarly, Zanubrutinib plus venetoclax in the SEQUOIA study was also shown to have very promising results, deep remissions, including in patients with del-17p. So all of these are really good, attractive, time-limited options that combine a BCL2 with a BTK inhibitor, and that can result in long disease control for a lot of patients. So this is kind of another approach, which is the FLAIR study, in which basically you decide about when you want to get to MRD and how do you want to continue therapy. So the MRD guided approach is also an option for some of those patients. Every trial has different guidelines on how this will be followed, but one of the examples is the FLAIR study, in which the Ibrutinib plus venetoclax combination was very effective and much better than conventional chemotherapeutic options. So again, another option which we don't use in the US as much, but in Europe, it's a perfectly reasonable option, especially for young patients who would like to stop therapy after a time-defined interval. So the BRUIN 313 study, basically, it's the Pirtobrutinib versus PR. Again, these are Can we move non-covalent BTK in the frontline setting? So these is essentially the data that we have. So Pirtobrutinib was better than bendamustine and rituximab in the frontline setting, similar to other BTK inhibitor. And it was also better tolerated in terms of the side effects that you see with chemotherapy. And we did see some bleeding issues with this, so you have to be still careful with this. But other than that, it was very attractive and did show improved outcomes as compared to chemotherapy in the frontline setting. And the next slide would be the CLL 314 study, which basically, again, was comparing Pirtobrutinib to Ibrutinib in patients who had treatment-naive CLL and also relapse refractory CLL, and it did show an improvement in outcomes with the use of Pirtobrutinib versus Ibrutinib. So now you have more and more evidence that the use of Pirtobrutinib in the frontline setting is potentially better than Ibrutinib and bendamustine and rituximab-based treatment options. So that does allow us an option to have a less toxic treatment modality for certain patients with previously untreated CLL as well as relapsed CLL. So in summary, so these things have dramatically changed the way we manage our CLL. And so for multiple patients, like I've said before, there are multiple different options that we can choose from. And hopefully with degraders and CAR T-cell therapy moving along nicely, we can hopefully cure or make CLL irrelevant for a vast majority of our patients. And happy to answer any questions related to that at the end of the presentation.